ovaries. We know that the ovaries basically have follicles. Those follicles were there from the time that they were born. In fact, when we looked at the chances of getting pregnant, the younger the patient is, the better the chances are. The best chance of getting pregnant is when everyone is trying to avoid pregnancy in college, right? So later on, they start, making plans for fertility, and at that point, they're usually in their mid-20s, late 20s, and in New York, of course, mid-30s, late 30s, sometimes 40s. And at that point, something is very challenging. We know that age is the main factor. So a young patient with endometriosis, even with a low ovarian reserve, has a very good chance of getting pregnant. Keep that in mind. Age is the main factor. But when you have an older patient with endometriosis, that combination can be very challenging. So we perform a transvaginal ultrasound, and during that ultrasound, what we do is we count follicles. Follicles are equal to 8. We also try to assess the ovarian volume. We try to rule out endometrioma, like this picture shows. And we draw a blood test on day 2 or day 3 of the patient period. We check an FSH, that's a follicle-stimulating hormone. We do that always with estrogen in the background because we know that's the culprit. And the FSH needs to be in the 1-digit number, meaning if a patient presents with day 2, day 3 blood that show that the FSH is in the 2-digit number, 12, 15, or above, then there is a reason to be alarmed and to be a little bit more proactive. There's really no specific cutoff, but FSH less than 12 is still considered normal, and above that is considered more challenging. In addition, there is a very good test that has been around for over a decade now called anti-Mullerian hormone. And I know Dr. Sechkin and Dr. Goldstein are testing older patients for AMH before surgery, during surgery, after surgery. So this is a very important marker. This is the equivalent of the guy's semen analysis. It gives you a rough estimation of what's the ovarian reserve at any given time. And the big advantage is that you can compare it from, time to time, from 6 months to a year. And you can also draw it at any given time, so you don't have to come on day 2 or day 3 of your period. A lot of our patients with endometriosis will be on birth control pills, as we know, to avoid this ovulation and the pelvic pain that's associated with menstruation. So those patients will never going to be able to get an FSH unless they were off the birth control for a month. So AMH is helping us in assessing that along with the ultrasound. Next slide. This is just an image of a 3D ultrasound of the ovaries that we conduct. So you can see that each follicle or each color there has one egg in it. And when we stimulate patients' ovaries for IVF or for egg freezing, we know that the patient with a lot of follicles will have a better chance of getting pregnant compared to a patient with a small amount of follicles. There's a straight correlation between this and the AMH. The higher the number of follicles, the higher the anti-Mullerian hormone, the AMH. AMH cutoff should be above 1. Below 1 is concerning and telling us that the patient has diminished ovarian reserve. There's also correlation between the number of follicles and the FSH that I mentioned, the follicle-stimulating hormone. The higher the FSH, the lower number of follicles that we'll see, and at that point we'll have a discussion about what are our options. Next slide. The day 3, as I mentioned, doesn't have a strict cutoff, but we know that levels that's above 20 is concerning. In fact, a patient who's younger than 40, who has an FSH greater than 40, is diagnosed with premature ovarian failure. And we have seen a lot of patients with endometriosis who had severe disease and started to present with hot flashes